All right, Dr. Pham with the Reach Center here.
And Kristen with Reach Specialties.
All right, and so today we're going to talk about hypermobility, which I'm really excited about because you and I both sort of have maybe some similar perspectives on hypermobility and some overlap in what we do. So I'm curious about what our initial evaluations look like for a patient who has hypermobility. I think probably both of us get referrals from pediatricians, internists, et cetera, either directly to me or directly to you. Oftentimes I do refer to a physical therapist. So what is your initial eval like?
Yeah, so first of all, everyone is super individual, and we kind of do a very long subjective. Sometimes the entire first session is subjective, kind of going through symptoms, tracking, hypermobility, dysautonomia stuff, MECSF stuff, MCAS, so kind of different buckets I'm looking at. A big one I like to do is walk me through your day. So
I like that.
When you're waking up, what's happening, when you're eating, what's happening, school, triggers, what's happening. So kind of putting a puzzle piece together.
Yeah.
Some people already know their symptoms. Some people have no idea. So starting tracking is a big one I like to do.
I think that's really interesting because I think a lot of people who have hypermobility will have other complaints, other issues that they don't realize might be related. And so having someone to ask those questions, then they can say, oh, well, yes, as a matter of fact, I do feel super dizzy, and my heart rate goes through the roof when I stand up. I had no idea what that was or that might be related. Or vice versa. Someone might come in for elevated heart rate when they stand, and you might ask, well, are you very bendy? What are your party tricks? For the little kids, they walk in and they show you. Look what I can do.
No, don't do
that. So I think there's a lot of overlap. What I tend to do is, obviously getting a medical history. Some people will come with a diagnosis, some will not. And like, what are the most bothersome symptoms? And then I like to get into like different sort of areas of function. So how is your sleep? How is your mood? What sort of physical activity can you do? And for kids, it's a matter of school. Like, what is your participation in school like? Because that's your quote unquote job when you're a child. And then in young adults, are you working? What does that look like? And how do you function in the world? So I think that's really great.
Beyond that, I like to look at all their joints, see hypermobility, most of them will be, but just checking where they are, compensations with functional movements, and then sometimes going through the criterias.
Yeah, definitely. And so we talked a little bit about this. So there are criteria for hypermobile EDS that I think are still in evolution. And then beyond that, if, for example, someone doesn't meet the criteria for hypermobile EDS, there are some instances when we would say, I still see a lot of hypermobility. Would we call this a hypermobility spectrum disorder? And I think it's really a global picture view. It's not just like, for me, my elbows are a little bit hypermobile, which means that, if I'm doing tricep extensions, I'm not going to hold a 15-pound weight with my elbow fully extended. But my score on the Baton scale is probably only a 3. Right. And so though I have some hypermobility, I don't consider myself to have a hypermobility spectrum disorder. And this is where I think spectrum is a really important term. And an important part of that sort of title or diagnosis, because it is a spectrum. And I think for me, when you add the word disorder to something, it really implies how something impacts your function and your life. So what are your thoughts on that?
Yeah, that's a good question. I think most people that come in that suspect it do have other things that they're dealing with. So sleep is impacted, school, life, anything you were saying. And so a lot of the things we'll do is look at bracing or school accommodations. That's a really big one I like to work with. Like shoe fittings, clothes fittings, compression, water intake. So I think there's a lot you can do with just a little information and just a little picture of them. And then usually it opens doors to this is wrong or this is doing way better. So,
right.
Yeah.
And I think as sort of heterogeneous as this population is, I think so are the interventions that can be helpful.
Yep.
And I think oftentimes taking a multimodal approach and working on all of those things can be really, really impactful. And I think that's one of the things that I love about being a rehab doctor is looking at the person as a whole, not just what is your blood pressure or, you know, my husband is an ophthalmologist. Like he has two things that he looks at and that's it. And I think as a rehab doctor, you get to look at the entire person. Yes. And the World Health Organization, the International Classification of Functioning, the ICF, really demonstrates that. And we use that a lot in research, in rehab, in looking at a person and all of the things that surround them. So their work, their play for kids, their family, what are the things that they enjoy to do? Like all of those pieces are really important in how you function as a person in the world.
Yep. And that's how I like to treat as well.
Yeah. This is why we work so well together. Anything else that we want to talk about in terms of that sort of initial evaluation for hypermobility?
Yeah, good question. Sometimes I'll screen for POTS as well. Usually we don't get to the POTS standing test. Usually that's visit 2 or 3.
Yeah. I think that's a really good point in that often there are so many different things for us to do and to talk about and to assess. And, you know, for me, I typically will like focus on the thing that is most impactful. Like what brought you in today? Yeah. You might have lots of hypermobility, but that's not what brought you in. What brought you in was the fact that you're passing out or, you know, you're having numbness and tingling in your hands and your arms are weak and you don't know why, right? That's the thing that I want to address, but providing that initial sort of guidance to say, hey, I think there are some other things that might be related and I want to explore those further, I think is really important because it takes a while to unpack all of those different pieces. So it's a process.
It is quite the process.
Yeah. So I think having that multidisciplinary team can be really impactful. And I know that's something that we're trying to build is a team of providers and even a document to help guide our patients. Who are the most likely providers that I'm going to be following with and knowing who those people are, keeping a list of them so that we all as providers can collaborate together because I think you end up getting better care.
Yes.
So anything else to add, Kristen?
No, I think you summed it up great.
Thanks, everyone.
Bye.